Hi, good evening, everybody, and welcome to week 5 of Rural Onboarding. And today we're moving on to specifically focus on child health, which is actually a huge responsibility that our districts have, looking after the children in those districts. And one of the huge aims for us within the district barometer is particularly looking at child mortality. And one of the things that every day in your outpatient, in your clinic, in your CHC, you're going to see children coming in with a wide range of conditions. And we are very pleased to have Dr. Shirani Naidoo with us today, who's going to be focusing on an approach to common ambulatory problems in children, and is going to give us some top tips that can improve our rural care of children. So Dr. Naidoo is a pediatrician with a subspecialist training in allergology and is currently a pediatric consultant in the Division of Emergency and Ambulatory Paediatrics at Red Cross War Memorial Children's Hospital. She has worked in various sectors of the healthcare system, including public and private sectors, and has been at Red Cross since 2012. So she has a particular interest in asthma, allergic conjunctivitis, and managing long-term health conditions in children, as well as health education. And I can already punt that we are busy organizing a webinar around allergies and asthma, specifically in May of this year, just around World Asthma Day, and we'll keep you updated on those. But with no further ado, I would like to hand over to Dr. Naidoo. Just a reminder, there will be a poll at the end for CPD. We have to give HPCSA some sort of proof. If possible, fill in the poll. That's the best way to capture you. If you completely struggle at the end of the presentation to fill in the poll, then please put your details in the chat so we can capture you for CPD points.
Good evening. Thank you, Madeleine. Thank you for that kind introduction. I'm going to keep my camera on for a few minutes so that you can see me and that you can see that there is a person behind the voice. And then thereafter, I'm going to close the video just in case we struggle with load shedding or bandwidth or any kind of problem such as that. So now we're going to all hope for the best, because I have incredibly poor luck when it comes to IT problems. It's a little joke with my students that every time we have a meeting, they wait to see what new thing is going to go wrong, because every time I manage to surprise them with a new and horrible thing that has gone wrong. As now, I promise you, Madeleine and I practiced this a few minutes ago and everything worked fine. And now I can't find my...
Look, there's a PowerPoint at the top there in the middle of your screen. Shirani, just there, if you look in the middle of your screen, it says an approach to at the top there. Just click on that tab.
Oh,
can you see
now
it?
I've lost it.
If you look
just
at
one
the
second.
Middle there, it says an approach to common ambulatory. Otherwise, what you can do is stop share and then open your PowerPoint again.
I think I'll do that.
And then you can share again. It's the nature of Zoom. It keeps us on our toes.
There it is. Yes, now obviously now I find it. There we go. All right, Madeleine, please confirm. Can you see it?
I can see it. Just put on, it looks beautiful. Thank you.
Fantastic. All right. So, as kind of Madeleine indicated, I understand that you guys are all starting, many of you are starting your community service, or you have been in a rural area for some time, and you are now faced with large numbers of children under 12 years of age who come to primary district level facilities, and it can be quite daunting. So I can tell you for myself, it was quite difficult to kind of think, how am I going to approach this? What are the things that I'm going to discuss? And so what I thought is I would just pick up a few resources and a few ideas, and then we'd apply them to a few clinical conditions, and hopefully give you a roadmap for how you're going to manage ambulatory and undifferentiated conditions as they come through. So at the top left, I think your most important friend and assistant is going to be the standard treatment guidelines. And this is quite comprehensive. And the things, the suggestions and medications contained in it should be applicable to every layer of care within South Africa. The next is a little bit of a Western Cape resource. It's currently being adapted and will be released very, very shortly, which is Pack Child. It is the companion of Pack Adult, and it is a desktop book, kind of an A5 little compendium that really has got a quite comprehensive overview of conditions that children present with. And those are two things that you can download, that you can access. They are free and they are open source, and they really contain the nuts and bolts. And there are many things about pediatrics that you don't need to keep in your head, like doses, because there are all those pesky milligrams per kilograms, but you need to have somewhere close to you. So those are two resources that I can suggest to you. The third thing is more of a philosophy. The first 1,000 days is a policy within the Western Cape, but it's also a way of thinking. The most vulnerable period of a child's life is the first 1,000 days of its life. But as well as being vulnerable, it offers a unique window of opportunity to shape healthier and more prosperous futures. And child health is really that kind of concept of making sure that we address not just medical issues, but all the issues that can affect a child with this long-term view in mind, that it is not enough to treat the condition that is in front of you, but that we must treat in a holistic fashion. And if we do, and if we do so successfully, we have the opportunity to change the trajectory of a life. And that's quite a powerful reason to get up and go to work in the morning. So, how do we approach ambulatory pediatrics? Now, I like having silly memes, so you must please bear with me with my pictures and my silly ideas. That when we look at child care and child health, that we know that South Africa, our healthcare system is skewed in many ways. It's skewed towards emergency care, towards crisis management, towards communicable diseases. Much of our time in medical school is directed at those conditions, and we are quite good at managing those things. Ambulatory medicine is the opposite of that. They are undifferentiated and ambiguous presentations. The differentials are very, very wide. Many of these are benign conditions. Many of these are not conditions at all. They're only age-dependent and developmentally appropriate expressions of childhood. In between that large number of undifferentiated and ambiguous presentations are some very serious conditions that have morbidity and mortality associated with that. And what you need in ambulatory pediatrics more than anything is the keen eye of the clinician that looks at the situation and goes, this is not right. Something is not right here. And the last thing that I'd like to introduce you to is the pediatric assessment triangle. This is a super quick way of looking at patients and very much suited to an ambulatory scenario. Very similar to the kind of A, B's, and C's that you would have met in your undergraduate training in terms of resus, but a way of looking at a child really quickly and trying to figure out if they are one of those children that you have to up triage to a red, or if there's something not quite fitting with that. So it is called the Pediatric Assessment Triangle. It's really emerged out of work done in India, where it looks at signs of illness that prioritize level of consciousness or the affect of the child or irritability of the child, or that sense in the healthcare worker or the mother, who is your other ally, that all is not right with this child. So the plan for this evening is that we would look at anemia, headache, and urinary tract infections as sentinel conditions, and then wrap up with some few thoughts that span all of them. So, if we think about anemia, what is the role of iron? And there are very, very profound biochemical processes that iron is central to. And these are things like electron transfer, binding of oxygen, cell growth, gene regulation. And I can summarize the space for you people is iron is ESCOM. It powers much of our body, and it really is indispensable. And now that I've told you about ESCOM, you will understand exactly where I'm going to when I speak about iron deficiency and iron deficiency anemia. Your body is capable of coping with low levels of total body iron but still preserving the levels of hemoglobin that circulates in your body. And you can go on like that for quite some time before you present with iron deficiency anemia, which is where you have depressed levels of total body iron plus an anemia. Now, because there is often a slow drop in HB, anemias of significance can be exceptionally well tolerated. In fact, frighteningly well tolerated in the pediatric population. So this is a global phenomenon. It's not unique to South Africa. It's a global public health problem. And there are certain communities where the prevalence rate in young children is up to 70% of the community. In sub-Saharan Africa, particularly, severe anemia is a major contributor to under 5 mortality. And the prevalence in much of the world in the absence of dietary fortification is staggering. It's 40% of preschool children, 30% in menstruating girls and women, 38% in pregnant women. And this isn't even including the elderly, who are another vulnerable population. So in these large numbers of people with iron deficiency and iron deficiency anemia, who are those who need to be reviewed, either carefully reviewed or need to be referred urgently or need active emergency management? Now, there are some that we all recognize. The child with cardiac failure, for example, has got a tachycardia as edematous, possibly is in shock. That is an immediate red flag, and that is the child who will need not just the pediatric assessment triangle, but will need a formal resuscitation assessment and implementation of resus strategies. The child is hemolyzing is another red flag, because the anemia that you have now is not the anemia that's going to be there in 6 hours or 12 hours as these red cells continue to lyse. Malaria is a very important cause of hemolysis in certain parts of South Africa, and increasingly sickle cell anemia is becoming prevalent in many areas. Sepsis and DIC. If there's any suggestion that your child has whole body sepsis, then whatever anemia they have becomes significant. The child who has a complex anemia, where the hemoglobin is low plus other cell lines have decreased, must be paired with the child who has potentially red flags for malignancy, because that is where we are concerned that the etiology is more complex and potentially contains a non-benign differential. The child who has an unexplained lethargy or has an unexplained decreased level of consciousness also needs careful review. And as a rule of thumb, if we want to put a number to it, an HB at less than 7 is where we want to consider referral up or more investigations. Why do we fuss? Again, Michael, what is the fuss if there are so many people with this issue? One of the biggest concerns is that anemia is very rarely the problem. It often coexists with a presenting complaint, and unless you are actively looking for it, you aren't going to look at these vague, non-specific symptoms of fatigue or lethargy or irritability or anorexia, which is odd because you often think these children would be hungry and they would want to eat, but that's not the case. Either their appetite could be off or their appetite could be quite odd. And pica is a very interesting phenomenon where children eat sand or paper or clay or often toilet paper, which is quite bizarre. But these are all quite non-specific features which in and of themselves would not merit another look. Do not think that you can rely on yourself to find pallor either. There was a lovely MA done a few years ago by Dr. Viecha, who is a pediatric ICU consultant in KZN now, and who only found that 18% of children who had significant anemias in my own facility, so I speak badly of myself, only in 18% of those patients was there a correlation between the clinical assessment of pallor and the presence of anemia. Peripheral findings are cholinergia, glossitis, angular stomatitis, possibly a small splenomegaly, also not the most obvious to signs. And then we come to the cardiac symptoms, where you could have soft murmurs all the way up to cardiac failure. There's a very strong association with socioeconomic status and HIV status. What are the outcomes that are relevant to child health? Strong. If you look at maternal health, we are looking to hard outcomes like antepartum and postpartum hemorrhage, postpartum depression. We're looking at stillbirths and IUGRs and preterm delivery. And these are hard drivers of poor child health outcomes, mortality and morbidity. And in child health, post the neonatal period, we are looking at long-term issues of physical growth, immune development, cognitive development, and stroke risk. And these would all depend on the timing, the severity, and the duration of the deficiency. Now, if you're going to think about why this is happening, we would look in two age groups, the child under 5 and the child generally over 5. I've included the immediately postpartum girl who's having an abnormal hormonal cycle that is leading to a short-term, a very heavy menstrual bleeding, just in this little group, because they are a small but special group. So the child under 5, we would go to look at history. Is there history, a dietary history that supports iron deficiency? Is there a history of pica, for example? We carefully evaluate for the absence of red flags. We do a few very basic investigations, an HP, possibly malaria, possibly a sickle cell screen, depending where you work, if that might be likely. We deworm, give the child good doses of iron. In fact, supplement the family because very often these things would be prevalent in the mom and other siblings. And then we look for a good increment of iron, which should be checked every few weeks. It's the non-responders only that would be sent forward for referral investigations, and iron studies only for non-responders. If you're thinking about other differentials, for anemia, we tend to be looking at intake versus need, loss, or malabsorption. And iron deficiency in the under 5 quite usually sits in this top circle of intake versus need. If you're thinking what I mean by a good dose of iron, this is a little table that I've gotten from Pat Child, and a similar one can be retrieved from the EDL, which tells you exactly how much to give of what. Now, what about child older than 5? Much bigger differential, much more. And here we need to supplement, but also we need to look for the source of the anemia, because without knowing what that source is, we'll find ourselves in iterative cycles of supplementation, failure to improve, and supplementation. So intake is still very important. And again, we have features extraneous to the family, poverty, malnutrition, famine. We have restricted diets for a variety of reasons. Losses become much more important, and the gut is a very important source of loss, where parasites and erosive parasites in the younger child, erosive GIT lesions start to come up in middle childhood, where we do see Helicobacter pylori and peptic ulcer disease, and the neoplasms, I think, are predominantly the province of adults, and very rarely a feature in childhood. But things like menstrual losses start to come up in middle childhood. And then we have patients who are iatrogenically bled, hospitalized, frequent investigations, and it's particularly in our preems, for example, it's very easy to underestimate how much blood they lose from the daily blood gases that are common in many neonatal units. Absorption is quite important, and this requires a quite detailed, nuanced history. Is the iron content of their foods appropriate? Is the bioavailability of their foods appropriate? Is the bioavailability being affected by the other things that they eat with those meals? And tea, for example, is a common offender in why a child fails to improve. Dietary choices, once again, we come back to religious, cultural, allergy, real and perceived. And then pernicious anemia is another type of, another differential that's possible. What is the baseline investigation that we want? We want our MCV. MCV low, we think about iron deficiency again. We think about occult blood loss. And in small letters, because it is possible but not my highest differential, we consider thalassemia, which is a common reason for small symmetrical red cells. A normal MCV would be, often we think of anemia of chronic disorders, and in our setting, we would look for TB and HIV first. If those were negative, we would then do a more thorough chronic disorder review. And just a little reminder that the anemia of chronic disorders is quite a complex business. It's got a multifactorial anemia. It's associated with cytokine changes, hepcidin changes, and quite abnormal iron homeostasis. And until one finds the source of that chronic disorder, you will struggle with this patient. An MCV high, obviously, we would think about folated B12. So this kind of brings us to the end of our discussion about anemia. I'm going to ask that if you have any questions, you put them in the chat, and then Madeleine can let us know, read them out to me at the end. And you also indicate if there's a question that's absolutely urgent that can't wait until the end of the presentation, that we have to discuss now about anemia, and I'm happy to take that kind of discussions. And Madeleine, you can just shout out if there's something urgent in the chat that I need to address, if that's all right. I'll just wait a minute. If I don't hear any voices, we'll move on to headache.
All well, you can go ahead.
Headache is one of those things. And if you don't mind my little joke, I'm going to go for it anyway. Headache is one of those things where you get a headache when you see this thick folder, because it's always a thick folder sitting there waiting for you in the box. Because it is a common thing. There is a romanticized notion of childhood, that it's this perfect, pain-free existence. And I think many healthcare workers are taken aback when they are frequently faced with abdominal pain and headache in the ambulatory setting. And that's the bottom line. Children get headaches. They get headache syndromes. They get migraines. They get clusters. They get tensions. And without a good understanding of the drivers and those triggers, no matter what you do, you're going to have poor resolution. So it's history, which is kind of the theme of ambulatory pediatrics. I've got my little pediatric assessment triangle because you need to have a keen eye. In between all the headaches are several really nasty things that you absolutely need to pick out. So affect and level of consciousness and higher functions, really important. A child who is confused or delirious is definitely not the common headache of outpatients. You need to look at the timeline with some detail. The acute headache that's less than 6 months needs a bit of a closer eye. You need a total understanding of the associated symptoms, all of them in great detail. Anyone who may have malaria or meningitis or meningism needs to be fast-tracked. People who have been vomiting, who have seizures, who have trauma, again, need to be fast-tracked. And the relationship with sleep needs to be examined in great detail. So a headache that wakes one up from sleep, or is present when you wake up, or it is severe in the morning, is somewhat more, in fact, definitely more of a concern than the otherwise regular headache. On examination, blood pressure is non-negotiable. Neurocutaneous lesions and eye symptoms are worrying. It's very important to know about moving. Things must move in the way they should, and anything that's not moving as it should or can't move is a focal sign potentially. I have a very low threshold for parenteral antibiotics, plus minus other cover depending on your work. So that may be malaria depending where you work. I work in Cape Town, so it's TB meningitis depending. Those are just the pathogens that are in my area. Always think about non-accidental injury, neglect, or abuse. These are not pleasant topics to think about, but they are our responsibility. And please remember about mental health. I'm just going to take a moment to direct you to quite an old article now. It's from my friend and my colleague, Bob Solomons from Tygerberg. It's in the CME, and it's volume 13, number 1 of 2012. It's not the most modern of articles, but it sets out the history and the approach very nicely. So now, again, I'm going to swing back to packed files and talk about some common headache phenomena that you might see. The muscular strain, the poor vision, the eye strain. Very common. Needs a holistic examination. Palpate the neck and jaw. Ask about the heavy school bag or the outdoor chores, because the muscular pain is common and you get base of skull headaches. So think about vision. Ask about the other factors that are going to corroborate a story of poor vision or eye strain, because I can tell you they are not going to be volunteered. You have to dig for them. Screen time. Screens are ubiquitous. Big screens, small screens, phones. So really ask about anything that can give you eye strain. Don't forget about common viral illnesses, prodromes, and associated symptoms of fever, body pain, coryza. Very, very strong association with headache, but you'll know this. And we do fluid and paracetamol. Definitely no aspirin, not in children. Sinusitis, not uncommon. We have a very high incidence of allergic rhinitis in South Africa. Up to 30% of the population has allergic rhinitis. And while we are quite good at diagnosing sinusitis with the frontal headache, that's worse when you're leaning forward, localized pain over the sinuses, possibly halitosis, and we are very good with starting antibiotics. We are very poor at making that link between the sinusitis and the allergic rhinitis and treating the allergic rhinitis. So if we leave the common behind us, if we move on to the headache syndromes. Now these are important. These take time because of the characteristic history that's going to come out. You really need a capacitated partner in your patients because the headache syndromes are long-term health conditions. They commonly have comorbid conditions, and you really need to work with the family around that. Tension headaches, classic history. A band, tightness around the head, comes on later in the day. It's exacerbated by fever, by poor intake of fluids, skipping meals. They respond to paracetamol, often may need NSAIDs as well. And you need to find what, if anything, is remedial. And the biopsychosocial model is absolutely imperative. There's very rarely just the one thing or the other thing. As you dig, so you'll find a medical component to it. You'll find a social component to it. You'll find an emotional component to it. And unless you deal with all of these, you're going to get a patient who comes back and back and back. There's dissatisfaction on both sides. And there is an escalating use of pain medication, which sets them up into a poor trajectory going forward into adolescence. Let's talk about migraines because this is the classic headache syndrome. It's got a very specific history. It can be auras. They are specific in their origin, radiation, often unilateral, often throbbing. They've got the photophobia and light sensitivity with that. Migraine should respond to sleep and shouldn't linger into the other day. But there's a caveat to that. The pain shouldn't linger on into the next day. There's often the sense of being not quite well or being just muggy in the head, which is it's an odd thing. So interrogate the history in great detail. There are some classic triggers. Poor sleep, hunger, stress, caffeine, chocolate, cheese, which are all interesting things, but don't forget that they're hormonal stressors. So in your postpubertal girls, please look out for an estrogen trigger. It's a nice condition to work with because you get a family history, you start a headache diary, and you start working your way through identifying and eliminating likely triggers. What's important to remember is that not all of these are going to respond to elimination. You can do it for 90%, but not all of these will be able to be ameliorated completely. So simple analgesia is important if you administer early. And this picture of the balls is important because for people with migraine, it really does feel as if something is doing violence to their skull. Waiting until pain is established is not going to help them. They have to learn their pattern. They've got to learn their trigger so they are aware. They've got to act early in terms of fluid and analgesia. And the family needs to buy into that. Many times you'll find a family that will go, they are taking too much tablets. We're worried about this. Isn't there something else that we can do? There are things that we can do. Simple analgesia doesn't always touch sides with this kind of headache syndrome. You do need to be very careful about who you manage and who you refer up. And the point of referral rates is there's prophylactic therapy. It's easy enough to think about stopping that red ball with little red ball on the side with analgesia, but it's even better if we can have a disease-modifying agent that takes the child out of the cycle of pain completely. Pack Child has given us a number, and they suggest that 2 or more attacks per month or no response to treatment should trigger a referral. I needed to specifically ask this question about space-occupied lesions because I remember being very, very anxious when I started about headaches and whether I needed to be imaging people more. So I asked myself this question: how often am I completely blindsided by a CT report? And there are two scenarios. One is stage 1 TBM, where there may or may not be a hydrocephalus. And TB is a vexing disease, and I've never quite felt that I've gotten to the bottom of it. So stage 1 TBMs still vex me, and I've still been blindsided by a CT report now and again. Non-accidental injury in shaken baby, those are conditions that have flummoxed me because I can't rely on the history. The history is sending me off in the wrong direction. But other than that, a repeated good clinical examination can actually steer you in the right direction most of the time. I could not find a kind of a up-to-date article that would substantiate that view. And the article that I found is quite old now, from 2002. But I had a long discussion with our radiologist, our chief radiologist at Red Cross, about her feeling about how often we CT'd patients and how often we were treating our own anxiety. And this is the most important thing. A meticulous history and repeated good clinical examination will not steer you wrong. So I'm going to take a second here again at the end of headaches, just to make sure we've got no urgent issues, no urgent questions before we move along. While I'm waiting for you, while I'm waiting for that, I've got a little bit of stats if anyone likes that. How common are headaches? I said that they're very common. So there's some studies that are found. There's an Austrian study I found that looked at in the EU. They looked at patients 10 to 18 years over a year, and they found an astonishing 75% prevalence of headaches in those patients, 80% in girls, and it increased year by year with age. So when I say it's common, it's impossible that you're going to escape POPD without finding some patients like this. All right, so we're good. So we can move on to urinary tract infections. So, not all urinary symptoms are going to be equal to a UTI. So, dysuria can be come from many things, and cystitis is not the same as a UTI. So, it's really, really important that you sample the urine correctly. And the bane of my existence is people who send bag specimens off to the lab. MCNSs are really, really expensive, and if we're going to go to all that effort and cost, it must be a good sample. A good sample would be a clean catch or a catheter or a suprapubic urine specimen, depending on the age of the patient. My other problem, and this is for those of us who work in pediatrics, is we forget that our patients' little babies grow up, and they grow up to become children, and they grow up to become teenagers. And teenagers need to be asked about sexual and reproductive health. So it's a very pediatric thing that I think we neglect the health of our young adolescents and adolescents, and we fail to provide them with good advice about sexual and reproductive health. Simple hygiene often doesn't get addressed well, and a travel history of Balatia depends on where you are. My enemy when it comes to UTIs is this little bottle there of bubble baths, which are so beloved by so many families and absolutely not healthy for delicate epithelial cells. That little girls get dryness and urinary symptoms that are not related to a UTI. So hygiene, either poor hygiene or hygiene that's thought to be good by the family, is a very important thing to consider. Now, similarly to what we did for headaches, there's a couple of symptoms that we need to keep our eye out because they are red flags that you are dealing with something else. Now, the first thought is, do you have urosepsis? The toxic child who's got fever, rigor, systemic illness. Very important to remember that this is not a simple UTI. Level of consciousness is really important. And again, I put my friend, the pediatric assessment triangle on the bottom left, just so that we remember that. Hypertensive encephalopathy can be very subtle, can be absolutely overt. And unless you go looking for things like that, and that can also be a feature of systemic illness as well. The child who has minimal urine or has anuria is in a different risk category, no matter what the trigger. It may have been a UTI, it may have been glomerulonephritis, but always inquire about the urine history. Blood pressure, blood pressure, blood pressure. It's not possible to properly assess a child with a suspected renal disorder without assessing the blood pressure, which can be challenging. You need to get a properly sized cuff, and that's not always easy. Edema. Edema is a red flag, be it of face or feet. I've repeated my little block about urine, I see. Minimal urine and anuria is a problem, but too much urine can also be a problem. The younger the patient is, particularly neonates and infants, can respond to a UTI by being polyuric. Proteinuria, important. When you have red cells, you can have some proteinuria, but the simple UTI should not give you significant proteinuria. Recurrent is important because recurrent UTIs may give you renal scarring, long-term renal damage, hypertension, or chronic renal disease. Glycosuria, very, very important. Urinary symptoms may not always be a UTI. Frequency, urgency may in fact be a symptom of diabetes instead of UTI. So these simple kind of diagnostic things are quite important. There are a few things that are important to realize, and we come back to what is developmentally appropriate. A parent may come to you with a story of abnormal frequency of urine and abnormal passage of urine, and what you may have is developmentally appropriate bedwetting. So being completely dry is not a thing that happens early in childhood, and there are many children aged 5 or 6 that still would still wet the bed from time to time. So full continence is not arrived at early in life, and continence that is not appropriate may also give you urinary tract symptoms. And here I'm speaking about the child with chronic constipation. And we often clump them together as dysfunctional voiding with the child with long-term constipation, who then starts to withhold urine, and then sets up a cycle of constipation, holding onto urine, getting a UTI. So these are things that would come up in history and examination. So when do you diagnose a UTI? Good specimens. So any culture from a suprapubic sample, a culture that has more than 10 to the 4 colony-forming units of a single organism from a catheter specimen, a midstream clean catch that has 10 to the 5 colony-forming units, or any consistent culture of a pure growth, even with counts as low as 10 to the 4 colony units. So when do we image? And this is from the EDL. We would do a renal ultrasound in all children with the first UTI. And here I just want to have a caveat. This is not the first UTI that you suspect. It's the first UTI that you approve. And this leads us back to our imperative of doing good samples as soon as possible so that we don't miss UTIs that we've just delayed because we've done that about, not sent the urine, and 1 or 2 doses of antibiotics have gone in. So why are we concerned about underlying abnormalities? Because they change the number of UTIs that we can expect, the pathogens that we can expect, and the consequences or sequelae are very different. And particularly young boys, it's posterior urethral valves that we are concerned about. And any child who has an abnormality that is detected on an ultrasound needs to be followed up with an MCUG. Now, what are the management issues? Let me return back to this imaging discussion. In case any of you are wondering, like, if there's been any research about this, how important is this? There's actually a dearth of good research that's going on about urinary tract infections. It's a common basic presentation, and very few people are looking at it in a critical way. There was a recent study that looked at the yield of ultrasounds And they came to, it was quite a big international study, and they looked at one kind of 5 children will have a positive finding on the ultrasound, but a far less number would have a finding that changes their management, actively changes their management. So perhaps you're going to ask me, with the challenges in a rural facility, the difficulties of transport, the long waiting lists at your referral hospitals, how important is it that we follow up this part of the EDR? And I will return that question to you back, is how easily accessible is renal replacement therapy, and how easily accessible is transplants? The problem with renal disease is that when things have gone badly, there's no sign to us, unlike the headache that speaks to us ages and ages. Headache. Renal disease is silent until we get to significant kidney injury. And in a low middle income country like ours, every single case that we can find proactively, manage proactively before we get to that point of chronic renal disease is important. And for low resource areas, preventive therapy is the most cost-effective way to go forward. So how do we manage UTIs? General supportive care. So hydration, nutrition, preferably oral and IV fluids if necessary. For recurrent infections, we're going to go to those general things that I spoke about at the start. We're going to avoid irritant soaps. We're going to avoid bubble baths completely. We'll treat constipation, and very often it is present. Pinworm is an important thing. Perineal hygiene is very, very important, and you're going to become tired of saying front to back before you leave POPD. Don't forget that the toddler is an extremely willful person, and this concept of a young child who doesn't want to go until they are ready to go is a very important thing. It's kind of an offshoot of toilet training. They become so proud of themselves with the fact that they are continent now. They will hold and hold and hold until they can't anymore. In the patient who has struggled with UTIs, a very useful technique is to make sure that you encourage double voiding, is where you encourage that child to completely empty their bladder. So they will pass urine, you will encourage them to wait in the toilet for another 5 to 10 minutes, make an additional attempt at voiding after the initial flow has ceased. And this is quite useful. What is the pharmacological management of a UTI? And here, there's a little bit to discuss. I'm going to make reference to an MED that was done at UCT a couple of years ago. Between February of 2016 and 2019 of July, at a district hospital in Cape Town, 528 specimens were sent off from children under 10 years of age who attended outpatients at that hospital. It would be Victoria Hospital in Cape Town for anyone who knows that. There are a couple of interesting things came out of that study. 528 specimens were sent, only 89 had a positive culture. So that begs the question, were those specimens well taken? Were they taken promptly? How many of them were delayed and had antibiotics, which skewed those results? So that comes back to what we spoke about before. Only 33% of those participants had a documentation of the urine sampling technique. So then I ask you, how do we decide, is this a real UTI? How are we going to manage this patient that is sick in front of us if we don't have that crucial information? And the diagnostic criteria depend on you knowing how that UTI was taken. What were the symptoms that brought children in? And they really relate to what we discussed at the first slide. Temperature instability, poor feeding, diarrhea came up in 30% of children, so a very common thing. And at least one urinary symptom was documented in half of the children. Dysuria, abdominal pain of frequency. And 40% of children needed admission. So while oral and outpatient therapy is really encouraged, many of these children would come with something that requires an admission. So what would the medical management be? It depends on your age. The younger you are, the more of a risk urosepsis is, the more of a chance that there's bloodborne spread, your sepsis is a real risk. For a neonate, IV antibiotics are absolutely essential. And my concern with the neonate is always meningitis. The classical organism of this age is E. coli, which crosses the blood-brain barrier very readily. So that's an important group of patients because they will need urine cultures, they'll need blood cultures, and very often they'll need LPs as well. The unwell infant under 90 days, again, your sepsis risk is high and very frequently has systemic symptoms of vomiting, which needs IV antibiotics. The duration of therapy in an uncomplicated UTI, more simple illness, we would be looking at 5 to 7 days. But in infants with acute pyelonephritis or septicemia, we are looking at 10 to 14 days of treatment. So these are really different diseases at different ages. And it's important for us to remember that the presentation, the age, and the sampling technique are crucial. But what about antibiotics? What is the right duration? What are the forces to be balanced? And the two things here are antibiotic stewardship versus antibiotic resistance. We know that antibiotic stewardship asks us to stick within EDL guidelines, to prescribe as on a national level, and to have the lowest amount of treatment possible. But we also know, and from the same study, that in Cape Town generally, we have increasing amounts of community-acquired resistant organisms. So of those 89 specimens that I discussed with you, 11 of those had some kind of ESBL producer, and that's a very worrying number. That's almost 1 in 8. 1 in 8 of those samples, and these were random children. They weren't nosocomial sepsis, they weren't frequently admitted to the hospital. These were children who presented to a district hospital. So that puts very nicely the forces that we are dealing with. We have the need for good management of a disease that potentially can be quite devastating if you have urosepsis or meningitis. And we have an increasing prevalence of resistant organisms at community level. And for those of us who work in outpatient and emergency facilities, it really does imply that we are going to have to build in a check in our management, that it is not enough to assume that your organism is always going to be found in the culture. Many, many children pass in and out of our hospitals without a prompt urine sample. We might miss UTIs if we are not vigilant. And even the urines that we do well, there's a 48-hour turnaround time minimum in labs. So a patient with diarrhea, for example, who comes in, makes a good recovery, and is out within a short time, I feel that we miss many UTIs, and it's become my practice because of this antibiotic resistance to ask patients to have a repeat urine dipstick at their closest facility after they've completed their antibiotics, just to make sure that we have closed this loop. Again, it's not a pleasant topic for me to open, but it's absolutely important that we consider the possibility of non-accidental injury. And the EDL has listed for us those children who present with a UTI in whom we must be vigilant and consider the possibility of non-accidental injury. So a child with genital, perineal, anal bruising, abrasions, lacerations, secondary incontinence, or marked fear of examination. Commonly in outpatients, you will also see patients present with discharges. There's an epidemic of abuse and neglect in South Africa. It is not within the scope of this webinar to discuss a proper approach to non-accidental injury. But this is the kind of topic that I would encourage Madeleine and Rudasa to consider in the future, because it is part of our responsibility for all of us who work in the sphere of child health to be vigilant at all times for non-accidental injury. And in fact, the Child Health Act, it's an imperative for us as healthcare workers to be on the lookout, and even one child that slips past our eyes is too many. So if we're going to wrap up now, we've spoken about 3 conditions. They are all common conditions. They all have age-dependent differentials in management. In all of them, history and clinical exam was the cornerstone. There were a few judicious investigations that we needed, all of them can present an emergency or deteriorate into an emergency. The EDL or provincial guidelines take you very far in management of all of these conditions, but not always far enough. All of them have instances and indications where referral and admission may be necessary. So it's important always to know your referral pathways, to cultivate good relationships with those referral pathways. And WhatsApp, frankly, WhatsApp buddies really are lifesavers when you're faced with something that is not quite within your scope of experience, or you just need a second pair of eyes on. So I want to thank everyone for having me. Thanks to Adasa. Thanks to the pediatric colleagues who are going to contribute with webinars, I think, later in the year. I want to encourage all of you to continue with some kind of journey with pediatrics and child health. I myself did the diploma in child health when I was a community service doctor. And for those of you who may be more experienced in pediatrics and would like to take things a step forward, I'd like to do a small plug for the postgraduate diploma in community pediatrics that's run through UCT in my department. I have some references. And my screen is frozen, my references. And then I'm going to stop here for questions.
Thank you very much. Very practical. I think we're going to have to bring you back a few times that you can. I love this, like the snapshots of sort of 3 common things, because there's lots of little things like that comes through our practices quite commonly, and these tips are very, very helpful. There are 2 questions in the chat specifically on anemia. The first question there is there an MC level low that would concern one enough to investigate for other causes further than iron deficiency on first presentation? So does the actual level of the MCV make any difference in your approach?
I wouldn't worry about the MCV. I would worry about the increment. South Africa, I live in Cape Town, I've told you that, but Cape Town is a port city. So we are notable for interesting genetic combinations, and we have such fascinating hemoglobinopathies in this country. So it's entirely possible that your patient is a tray of something. There are thal trays, thalassemia trays, there are spherocytosis, etc., and those things become apparent on your second full blood count. So even if the first MCV causes you acute anxiety, hang in there. If the child is stable and you don't have red flags, start with your iron on that first presentation. So how much increment do you expect? At least 1 gram per deciliter per week. I think that's fair. In your patient with chronic illness, which I see is the second question about how long does it take to normalize after a patient's put on hematinics, it is the iron deficient patient who responds the best. If it's only iron deficiency, they lap up that iron, the HP takes off like a bomb, and within, usually we should measure at about 3 weeks the first time, and you should see a good 2.5 to 3 increment. Then you know you're on the right track. If things are not going well at that point, I go back to my medication and I go back to how it's being taken. Has anyone ever taken iron in their lives? It is vile, vile, vile. It causes a whole host of GIT symptoms, and people often stop taking it. So when things are not going well, the first problem is usually the iron. It was not enough, the problem was you. It's not been taken probably because you didn't explain it well enough to mom, and you didn't prepare her for those horrible side effects, like a bit of tummy cramps or constipation, or that the stool goes horribly black. So first visit, hang in there. Second visit, if things are not working, check that the iron administration is actually going in, and then the visit thereafter, if the HP and the MCV has really not budged, that's your time to start thinking about other things. And the thing that I found most often then is, again, I'm from Cape Town, and we have a lot of thal trays. So you see HPs that don't budge. Because the child has got another condition. You see an MCV that doesn't budge because the child has got another condition. So anemia of chronic illness, how long does it take the HP to normalize after a patient is put on hematinics? And since the cause is known, is there a need for further investigation? It depends. It depends if that was the only problem. For very few patients is that the case. And usually there's comorbidities. And I'm going to give you a perfect example. A child who has TB and also has food insecurity. So you will find the TB, you'll diagnose the TB, you'll start them on medication. And they often have that period in the ward while you're stabilizing them where they start to look better, they perk up, they gain some weight, but the HP may lag a little bit. That's okay. But never assume there is not further investigations needed. It might not be fantastic investigations, but deworming, etc., etc., etc. Many of our patients have more than one pathology. So look holistically for everyone and suspect every child of potentially being trouble until you've explored on history. And often it's silly things like the child with TB who's got food insecurity, or child with TB who's got food insecurity and mother drinks lots of tea. So go through the exercise of thinking your way through it. You don't need to investigate everyone, but make sure that you follow up. That study that I referenced, Dr. Viecha did it in my own facility. So I can tell you that we are awful at the following up. And we're great at the diagnosing, the fancy, but it's the follow-up that's most important, because you need these children to return to a state of being iron replete. And I didn't have enough time to stress that properly, but it's iron replete that we need. All of those negative outcomes that I discussed, they come from being iron deficient. So if you just treat the anemia, it's like stage 4 load shedding versus stage 2. You know, we've all learned to love it for stage 2, but the stage 4 that we complain about. So when you're dealing with iron deficiency, you really want to make sure that the child has built up their reserves again. So there's Madeleine, I'm just reading out the questions. I've just
Welcome
gone
to
on.
That Works for You, Nancy. There's one last question there about UTI, yes.
So Adwa has asked, for UTI, do you wait for positive cultures to start antibiotics, or do you start based on clinical symptoms? Now that really depends on who you are and who your patient is. I will tell you this, I'm an anxious pediatrician. So I don't like to wait. If I'm worried about urosepsis, I treat first. I feel that it's better for me to start big and rationalize later than to wait and allow a patient to deteriorate in front of me. So now I also come from early life experiences. Like many of you, I was a Cosmo in Queenstown and Frontier. A lot of patients had poor outcomes because of malnutrition, what. So I've had many negative experiences, so I don't wait. My problem is antibiotic stewardship. So I start broad and I have to consciously work on that of going, use the least amount of antibiotics, the most narrow spectrum for the shortest period of time. So that is my bias. And on a practical perspective, if there's a 48-hour waiting period, can you wait? Any specimen sent from my hospital on a Friday is not coming back until Monday afternoon. The lab doesn't even look at it. So there are many practical things about that answer. It depends on how far you are from the lab, how quickly the turnaround time is, et cetera, et cetera, et cetera. It's not possible for me to wait for cultures. Dr. Maposa has asked a tough question. Is there a role for venofer? I'm thinking this is parental iron when treating kids with anemia. So I work within the state and within the public health system at all times, and particularly at this time. The budget. So we have two treatment options. One which is evidence-based and cost-effective, and that's oral iron. And we have another option that is far more expensive and has a risk for adverse events. And there is kind of anaphylaxis type things associated with parenteral iron. So I have posed the same question to our colleagues in hem-oncology, and they go, "Puffle, there's no need for it." But I don't think you should ever say never, that there is no role for something. There are children who have absorption issues, possibly children with concomitant GIT conditions. So I would hesitate to say no, but it's not a big role. And it's not something that we use very often in my setting. I do know that my colleagues in private are a little bit more ready. But it's not a part of practice at my facility.
Thank you very much. I think that's perfect timing. We've exactly 1 hour since we've started. And thank you so much for making the time. And we really look forward to having you back in May. I also really like the idea of actually looking at non-accidental injury at some stage as a specific webinar later in the year. It's, as you say, it's important, and because it's difficult, it's sometimes something we sort of feel slightly in denial about when we are seeing children. We don't want to think that the world is like that. So I think having some practical approaches and things to consider would be very useful later in the year as well. So we're definitely going to be inviting you back. Tomorrow morning, I will be sending out the resource packs. It will go with the normal Rudasa forum letters, where there will be a link to resources specifically for children, and I will include that link to download the 2023 Western Cape pack for children as well.
Pack Child is having some small modifications, so that link I don't think we should use, but as soon as it's finalized, I will send it to you.
Okay, that's great. So that's good. Then I'll take it out so we don't use it for tomorrow. But just to punt it, that something will be coming soon. And I do have the IMCI there in as well. I don't know what you think of IMCI in comparison with PAC. We've got the 2022 IMCI that's also available on the Knowledge Hub. That
IMCI is fantastic. A capacitated nurse partner is really, really important.
So I think we forget about
it's
this
really
great.
Fantastic.
Yeah. So if you're feeling nervous, especially if you're new ComServe and feeling a bit overwhelmed with a sick child, get your IMCI out, and it will help you to systematically make sure that you're not missing any of the red flags and that you are treating that child adequately. So thank you very much. I'm gonna end the meeting here tonight, so you all can get back to your families and to supper. And once again, thank you very much, Dr. Naidoo.
It's such a pleasure. Good night, everyone.